Hello, everyone, and welcome to Preemie Chats, a space where we connect, learn, and share stories about the world of prematurity. I'm Leah Whitehead. I'm the proud parent of a preemie. I'm also a former journalist. I'm so honored that you have joined us here today. Preemie Chats is brought to you by the Canadian Premature Babies Foundation. You may also know them as CPBF, a parent-led charitable organization dedicated to supporting families, advocating for the needs of premature babies, and providing the latest information and research to help parents and caregivers navigate this journey. So whether you are a parent, a healthcare professional, a researcher, or just someone interested in learning a little bit more about prematurity, you are in the right place. Together, we are building a supportive community where stories are shared, questions are answered, new evidence is explored, and no one feels alone. Be sure to visit our website there on the screen, canadianpreemies.org, where you will find helpful resources, our latest projects, and most importantly, a community of people who want to see our little ones thrive. If you're watching live today, I invite you to please join in the conversation in the comments, share your questions, let us know where you're watching from. It's always interesting to see where people are tuning in from, and the questions we'll address at some point during the program. So it's also a way to interact live with our experts who are on the episode. It is through meaningful discussions like the one that we are about to have where we advance, practice, and grow together. And so please bring your voice to the table. Every voice is important to have here with us today. You know, there are so many unanswered questions when it comes to preterm birth. And I know for me and so many families who I've spoken with over the years have had to come to a certain amount of acceptance of some of our questions will never be answered. But this doesn't mean, however, that there aren't those who are still committed to learning more and finding best practices to create better outcomes in the world of preterm birth. Steroids is one of those treatments that tends to have a lot of question marks beside it. And when early birth seems likely, steroids are often given during pregnancy to help babies who are born too early. Like all treatments, though, there are risks and benefits to antenatal steroids. So today we're going to hear about both from someone who is passionate about best practices when it comes to antenatal steroids. Dr. Sarah McDonald is a maternal-fetal medicine specialist and professor in the Department of Obstetrics and Gynecology at McMaster University. Her research focuses on prevention of preterm birth and its long-term effects. She loves food, especially snacking, and so she nicknamed the trial, the steroid trial that she's involved with, SNACS. And so she's joined us here today to share her wisdom. I have had the joy and privilege of hearing Dr. McDonald talk at EPIC a couple times, and her insight is amazing. So thank you so much for joining us here today, Sarah.
Oh, thank you, Leah. It's such an honor. I feel incredibly privileged to work with preemie parents and CPBF, and so thank you for this chance.
And I'm going to let you get right to your presentation. And then, as I mentioned, if people have questions, please put them in the comments and we will get to those after the presentation.
Great, thanks. I hope there are lots of comments. I really like the chance to interact, so please do put them in. So before an early birth, how do steroids help? And if you're already a preemie parent, you may know much of the information on the slides. Hopefully this podcast will also help some parents who are potentially facing an early birth, and so it's kind of directed at them. Today, I'd like to cover how an early birth can affect babies very briefly, what steroids are, the benefits and risks of steroids, and other resources. Some babies are born very early, and I really hope that's not the case for you if you're listening to this. However, the good news is that the risks can sometimes that go along with being born very early decrease the later the baby is born during the pregnancy. So I like to show that with this green arrow going downwards. What are steroids? The steroids we use if there's a risk of an early birth are sometimes called corticosteroids. And they're a kind of medication that are manufactured forms of hormones that our bodies make naturally. When people first hear the word steroids, they sometimes think about the steroids that are used to build big muscles. But that's not what the steroids are that we use during pregnancy. It's a completely different kind of steroid. The steroids we use during pregnancy, if there's a potentially early birth, speed up the development of various organs in the baby. And when we give them to pregnant patients, the medication travels through the mother's blood across the placenta to the baby. And I like to show that with this little picture here. Apologies for my artwork. Steroids help babies born very early in many ways, including improving survival, helping organs develop like the lungs, but not just the lungs, the bowels, and the brain, among others. Let's look at this in a little bit more detail. So we know that steroids can improve the survival and other outcomes for babies born very early. And we know that babies born later in pregnancy have better chances for survival and fewer complications than babies born very early. And if we dive a little bit deeper into, for example, survival, if this pictogram shows one baby born very early that survives, and the purple pictogram unfortunately shows one baby born very early that does not survive, overall, in babies exposed to steroids during pregnancy, about 100 out of 100, about 80 babies born very early survive. And so I've shown them here in green. And if a complete course of steroids is given, about 4 more babies out of 100 survive than without any steroids. Now let's look at how steroids can help the lungs of babies born very early. One way that steroids help babies born very early breathe easier is they help the lungs to make something called surfactant. So I've got a little picture on the right of an air sac in a lung. And when we give steroids, the steroids stimulate cells within the lung to produce surfactant. And surfactant is a kind of soapy-like substance that helps the baby breathe better because they help the little air sacs to stay open. This isn't the only way that steroids help babies born very early breathe better, but it's one key way. Steroids can also help babies born very earlier by making bowel problems less likely. And they can also help babies born very early by making problems with the brain, such as bleeding in the brain, less likely. And thankfully, those serious complications also go down as the pregnancy progresses. Overall, steroids help the organs of babies born very early, including the lungs, the bowels, and the brain, and all of those things help babies survive better. Now, the impact of steroids changes over the course of the pregnancy. Since the challenges that may go with a very early birth decrease as a pregnancy progresses, steroids are less helpful when the baby is born later. But steroids can help babies born very early, although their benefits become smaller as the pregnancy progresses. This is why guidelines suggest using steroids up to about 34 weeks and 6 days, or some say 34 weeks, during a pregnancy. It's very hard to predict when the baby will be born. Thus, among babies that are born who receive steroids, about 1 out of 2 babies born early will benefit from the steroids because they're actually born at a point in the pregnancy where they're helpful. And about 1 out of 2 babies that are exposed to steroids are born at or near term and do not benefit from the steroids or benefit really in a minor way. For babies that are born at or near term, there may be increased risks of behavioral or mental challenges after exposure to steroids. Since 1972, we've been using the same dose of steroids. Here's a picture. I love the black and white nature of it, and when I sometimes show this to patients, they're absolutely astounded, which makes me feel a little old. These are the high-risk obstetrician and the neonatologist who conducted the first high-quality study on steroids, and they use the same doses of steroids that we use now. And that's because when you're doing a first-time medication trial, you pick a robust dose, and then you should go on and study lower doses. And for some reason, that was just never done. The doses that we're using now and that they used back then, last century, in animal studies have been found to be perhaps 2.5 to 10 times higher than what is needed to achieve a therapeutic benefit. Overall, we know that steroids improve survival and challenges in babies born very early, but this benefit decreases across pregnancy. And if the baby is born at or near term, there are potentially risks. And this is part of the reason why we're doing the SNACS study, as Leah alluded. My husband actually nicknamed this because he knows I love to snack. It stands for a single dose versus double doses of antenatal corticosteroids. And I'm incredibly grateful to the CPBF for partnering, for being one of our parent partner organizations in the study. And parents from CPBF have helped us to design the study right from the get-go, right when we were considering the question we should study, and they had valuable input into nudging us to consider longer-term outcomes. So right now, parents who come into the study are agreeing to follow up at 24 months, but our parent partners have really urged us to look beyond that because they've said to me, rightly so, Sarah, we want to know the impact when our kids go to school. Is 2 better than 1? Is 1 better than 2? Are they similar? In which case we should be using 1 dose. SNACS is a high quality research study, meaning that parents who agree to come into it let a computer decide whether they're going to get a second dose of steroid or a second dose, an injection of just a placebo saline. Why is that important to let the computer decide? And it's to prevent bias, because we don't want well-meaning doctors, nurses, even parents thinking, oh, I should have this. We just want the babies to tell us the truth. At the end of the study, we'll know which group every baby was assigned to, and the babies will tell us what the right thing is. Parents who've previously enjoyed participating in pregnancy research studies were motivated by things like health benefits, protecting their baby, access to particular care or special attention, helping others with their research in an altruistic way, learning opportunities. They particularly like studies that are simple or convenient and that have a low time commitment, which makes sense because parents are busy. They lead busy lives. And I think SNACS ticks many of these boxes. I just want to close with a heartfelt hope for the best for your pregnancy and reassurance that you are not alone. Leah led in with that, and this wasn't planned. I didn't know she was going to say that, but I think it's so important to say that we both naturally gravitate towards that. There's a team looking after you if you're in hospital, potentially facing an early birth, and they want to support you. I also would add that there's a community around you, especially CPBF, especially the Canadian Premature Babies Foundation, over 2,000 parents who know the path you're walking and who can reach out to support you. And so beyond your care provider and beyond the Canadian Premature Babies Foundation, I also just want to mention Hand to Hold, peer support organization that helps parents cope with the situations that they're finding themselves in, facing potentially a premature birth. I want to close by wishing you the very best for your pregnancy, and hope that you might have questions that I can chat with you about. So I'm going to stop there.
Thank you so much for your presentation. There's always so many questions. As I talked about in the intro ahead of time, I think a lot of people have questions about steroids because there still are a lot of questions about them in general.
Mm-hmm.
So we have one question from Sandy. So Sandy is a preemie adult. She was born in 1994 at 29 weeks and had IVH grade 1, RDS, and ROP stage 3. Sandy is now graduated, I believe. You can correct me if I'm wrong, Sandy, as an RN. And so her question is if pregnancy, and she's watching from Taiwan is the other bit of info she gave us as well. Now she said if pregnancy is 21 to 22 and 6, preterm birth, should you be giving, now these I know dexamethasone for sure, or betamethasone?
That's right.
And thank you, she said. So
hi, Sandy. Thank you for joining, and thanks for your question. Boy, you've asked a tough one. So I hope you'll let me give a kind of long answer, because that's typically, I'm not good at telling half the story. So the high quality evidence that we have for steroids comes from randomized control trials, where we've tried to reduce bias and where the computer randomly allocates the pregnant person either to 2 doses of steroids or 2 doses of water. Those high quality studies included babies usually from 24 or even later, sometimes 26 weeks, etc. And so we are going to have to look outside the highest quality studies if we're going to address your important question. And I think as we improve neonatal care, improve antenatal care, we are offering parents the possibility of resuscitation earlier and earlier. There is some non-randomized, so the next tier down, where there's a potential for bias evidence that suggests steroids are helpful before 24 weeks. To my knowledge, those studies were mainly in the 22nd and 23rd week. I'm not aware of studies looking at steroids given in the 21st week. The earlier in pregnancy that we're contemplating giving steroids, we have to remember that those lungs are even more mature, and the number of alveoli, or the little air sacs, are even smaller and less frequent than they are by kind of magnitude, multifold at 24, 25, 26 weeks. So I think but your question should begin with what are the parents' wishes around resuscitation, Sandy? In my center, resuscitation isn't an option until 22 weeks because the outcomes of the babies before that are just so difficult. And even at 22 weeks, our neonatologists, I think, do an excellent job of having a really thorough discussion with parents about what those challenges might be. Ideally, I think we want to time a course of steroids within the best before date, within 7 days of delivery. That's really hard to do. And so for me, the starting point to your question is, what would that mom want in terms of resuscitation at, say, 22 weeks? If parents are clear, they've spoken to neonatology, they understand, and they want resuscitation at 22 weeks and 0 days, then in my institution, if we think there's a high chance she's going to deliver in the 22nd week, we do give steroids at 21 weeks and 5 days and 21 weeks and 6 days. We don't typically give it before them for the reasons that I mentioned, that resuscitation isn't offered in my institution before 22 weeks. And in many, I think across Canada, that's the case. I guess that was a really long answer. I I hope I covered what you were asking. If you want anything tweaked or I need to repeat it, please just type it in the chat, and Leah will bring it back to us.
I love that in your presentation, it was very clear. And so you can tell that you speak to families a lot because, you know, there's things that we try to pick up as parents that is really trying to wade through medical terms. And one thing that I learned in your presentation was that I always thought that the steroids were only given to benefit babies' lungs. And so I didn't know that it also helps bowels and brain, which is interesting.
Yeah.
And sorry, go ahead.
Yeah, thanks for that, Leah. So it decreases severe bleeding in the brain, grade 3, grade 4 hemorrhage, and also severe bowel problems, necrotizing enterocolitis. That's a mouthful, isn't it? But that's and I think many of the parents on board know exactly what that is. But in case there's any parents who haven't yet experienced that and haven't spoken to neonatology, it's a condition that affects preemie babies' bowels where they're just not ready to function yet, because in utero they don't have to handle food, and the stress of that. And I always clarify with parents that we're not talking things like constipation. We're talking serious bowel dysfunction where they sometimes need to stop the feeds going through the tube into the baby's stomach. Some babies need antibiotics, and some babies even need surgery for potential bowel perforation. So yes, steroids help all those things, even other things as well.
Mm-hmm. I wanted to talk about that window of time that the steroids are beneficial. And so I think you are talking about the 7-day. Is that right? That you get your first course of steroids, then you're supposed to wait 7 days and do a second course. But then, is that right?
No, thanks for the chance to clarify. So ideally, we really want to time steroids within 7 days of birth. Okay, you opened up another good question, so give me a second. I think the question of repeat courses, and I personally advocate that we stay away from the word rescue, because I think that's pretty value-laden word. So just to go back, with one single course, there's benefit in every major illness that can face babies related to prematurity in terms of lungs, brain, bowels, and survival. With a repeat course, there is no benefit, and there's a benefit with respiratory disease, lung disease, because if your lung tissue, you always benefit from more steroids. Any patients out there who are asthmatic, any patients with rheumatologic diseases, you know what I'm talking about, right? But the question is, what are we doing at the benefit of mild breathing benefits with a repeat course? What are we doing to other organs? And we know from high quality studies that have followed children up, we have impacts. So head size is smaller. Head size is a surrogate of brain volume. There's an increase in statistically significant attention deficit disorder with repeat courses. So we really try hard, particularly in Canada at most centers, to hold that first course close to the time of delivery. And most centers in Canada, for the reasons I've mentioned, don't institute a repeat course. The lungs will benefit, but what are we doing to other organs? Well, we know what we're doing to the brain.
So are people doing repeat doses because they're trying to hit that window of benefit, because it only lasts a certain amount of time until baby's born? Is that right?
Yeah. So you grow more lung tissue happily as the pregnancy progresses, and the farther you get from your first steroid, you're growing more and more lung tissue every day. And that's not exposed to steroids. Any new lung tissue, a little while after the complete course, meaning 2 doses. So one complete course is 2 doses of celestone.
Okay.
Or betamethasone. So as you grow more lung tissue that's not exposed, and as that steroid, is no longer the fetus's body, then it's not impacting those other organs that we talked about to the same degree. It's not a hard and fast rule about 7 days. It's that we know as time goes on, the benefits decrease. There's some evidence around the 7 days. There's some for 7 to 10. There's some for 7 to 14. The good news is that steroids appear to have an impact, a beneficial impact on survival within a few hours of the first dose. So that also gives me courage to try to push that first dose, but out of 2 doses, to complete 1 course as close to the time of delivery as possible. But we also don't want to miss the window, especially on very early babies. So, at the edge of viability, 22, 23, 20, 24, I think having the steroids on board, even if it's outside of the 7-day window, is still going to benefit babies. And it's much more important that we get that course of 2 complete doses in, than miss the potential opportunity to give babies steroids. I guess I should say, actually, that there's been a recent high quality study called Beta Dose that looked at 1 versus 2 doses and didn't show safety concerns with the 1 dose, but their main focus was a need for a breathing medication, surfactant, after birth. About 1 in 5 babies, whether you were in the single dose group or the double dose group, got a dose of surfactant. And in their study, it was something called inconclusive, meaning it wasn't clear that there was a benefit towards 2 doses compared to 1, and therefore they're waiting for our results in SNACS. But the good news was survival, whether you got 1 or 2, in this high quality large study of over 3,000 patients, 97% in both groups. Breathing problems, bleeding in the brain, or bowel problems were not significantly different between the groups. So I maybe need to revise my language that maybe giving 2 doses, but I just wanted to try to answer your question, sorry, about the 7 to 10 days, which was a few minutes back, but that's my long answer to it, is ideally steroids close to the time of delivery, but it's better to have them on board and have a bigger window after the steroids than to miss the window. And I wouldn't advocate repeat for the reasons I mentioned, that the highest quality evidence doesn't show benefits in the major morbidities or mortality. Mild respiratory disease will still benefit, but we know that the brains have impacts from the repeat.
Sandy clarified a little bit here and said, if mom's in labor at 21 to 22 and 6 or 23 to 24 and 6, could there be an increase in survival or reduce IVH and RDS?
So we don't have high quality evidence to answer before 24 weeks. That's just missing. It looks like in the next tier down of evidence that maybe there's benefit in the studies that have looked at 22 and 23 weeks. Just to repeat, to my knowledge, there are no studies about giving steroids in the 21st week, to my knowledge. And so there may be benefits in the 22nd and 23rd week. And if a mom wants resuscitation at 22 weeks and 0 days, then we do give steroid, and we think delivery is going to be in the 22nd week, then we do give steroids just before that. But the degree of certainty with which we can say that just isn't as high, because these aren't the very highest quality research where a computer randomly assigns people, so there's not bias or prejudice creeping in.
She also asked about if mom was in labor but not waiting for betamethasone or dexamethasone, could you use oral betamethasone or dexamethasone?
So I would not advocate that. The intramuscular betamethasone and intramuscular dexamethasone are where the evidence has been created. So I would not advocate using oral at this point. I would advocate using betamethasone or dexamethasone. There are trials. Maybe Sandy's a researcher or just got her finger on the pulse. There are upcoming trials, and I think trials in the early days that are looking at oral preparations, but that's not where the body of evidence comes from. The body of high quality evidence to date comes from intramuscular injections of either betamethasone or dexamethasone.
I have a curiosity question for you that, as you know, I did receive steroids before Tessa was born at 28 and 1. I think we got our steroid shots around week 24 because Tessa did stay in longer than any of us.
Yay!
Yeah, I thought she would. So that was good news. But I always wondered about long-term effects, because she has everything early. Her teeth came in early. There's been other kind of physical milestones that happened early. And in my mind, it was, I wonder if this could be related to the steroids she got antenatally. And we had 2 courses of it before she arrived. And so is there any research about that and kind of the long-term effects on our babies? And do you think it's possible that that plays a role?
I'm not aware of long-term research on that kind of thing, like, for example, teeth coming in early. I'm not aware of that, or do I think it's possible? You ask great questions. I know nothing about teeth. I know you're just giving an example, but to be transparent, yeah, I'll hold further comment on teeth. There's been surprisingly little follow-up in high-quality studies, and that I actually find completely unsatisfactory. As a researcher, as a clinician, when I'm talking to parents, so we mentioned high-quality studies where the computer randomly allocates people to prevent bias to either get 2 doses of steroids or none. In those 2 doses of steroids, meaning 1 complete course, of those high-quality studies, there have been over 30. If you wanted to guess how many followed beyond neonatalhood, babyhood, if you guessed 3 out of 30, you'd be correct.
Wow.
Babies were born in the 60s, 70s, early 80s, last century. Thankfully, very little else of the care that I give as a high-risk obstetrician looks like 60s, 70s, and 80s. And neonatal care, I mean, it's a completely different world. Thankfully, progressed. Why haven't we progressed with steroids, right? Why am I doing something half a century old? Because nobody studied it in depth until beta dose. The French study that I mentioned that looked at 1 dose versus 2. Bravo, the French, first high quality study to question what we'd been doing for 50 years and suggesting maybe we need to rethink 2 doses. But as I mentioned, they're waiting for our results. 3 high quality studies out of over 30 following up into childhood. That's not good enough. We've got to do better for parents. I have not met a parent who's only in it for the babyhood part, right? They're in it for the long haul. They're signing up for the child's life, right? We've got to do better than that, not just with steroids, but all of our interventions that we're doing. We need to look at longer term impacts. It's really hard to do, and we need our funding agencies to fund those long-term studies. It's expensive and it's hard, and we got to not do it. We can't keep saying to parents, I just don't know. I don't have any evidence from this century, I'm sorry, that's high quality, that looks at long-term follow-up. We've got to do better than that. Preemie parents deserve better than that. And so We're hoping to fill part of that void with SNACS. Beta Dose is hoping the French trial to fill part of that void. But that's where we stand today, is very little long-term follow-up of high quality evidence.
And that's part of that question mark that I was talking about. Like, there's so much. And I think as parents, when we see things in our children as they grow that is different than their peers, that question mark reappears for us of, could it be because ...
Right.
That steroid element has always been a question for me, because to be honest, that, and I'm so glad you talked about the muscles at the beginning, because that word is one that I think is a scary word for parents, because steroids are serious when you see them being used in the medical world or anything. You see that, that it's an intense treatment. And not to say that not a valid, because your numbers show that it is, but it's always that thing that's kind of like, what else could this have done or will do?
I agree. There's a saying, with great power comes great responsibility.
Yes.
And steroids are powerful medications.
Yeah.
They're not targeting, they definitely help the lungs of babies, but they're not solely focused on the lungs, thankfully, right? Because of some of the potential other benefits.
Right.
But yes, with great power comes great responsibility. And I totally agree. And I think part of that responsibility is we need to be able to tell parents in the long term much better information going forward. And so hopefully parents will advocate, when studies are being done, for long-term components, because we've and encourage, I don't mean to put this on parents, I just mean have powerful voices. And so I'm just encouraging them, as I speak to myself and say as a clinician and as a researcher, I need to advocate for that as well. We've got to do better, and we can, and we will.
Holly McQuarrie had a similar thought to me, that, she said, I think it's interesting that it's been the same dose since 1972. And Holly's daughter was born at 25 and 5. And she said she got 2 doses of steroids before baby was delivered. And so she said she learned a lot from your presentation. But I think that number is shocking, knowing that, like you said, it's been just a practice that has carried on. And do you think the dose is too high when you look at what it's showing with the animal studies, or do we feel like we've still hit a good spot with that? I'm sorry, I'm putting you on the spot.
No, that's, I paused because I want to give you an honest answer, and the honest answer is I just don't know.
Yeah.
That's why I'm doing SNACS, is I just don't know. Alan Job is a neonatologist, and he and his colleagues, Matt Kemp, etc., have done a lot of the foundational work in animals. That's where I get that number, that maybe 2.5 times to 10 times higher than what we need. Interestingly and anecdotally, I'll tell you, the dean of my university, my medical school, is a respirologist. So he's a lung doctor. And he told me when they started treating asthma, they were using 10 times too high the dose as well, when I was talking to him about the steroids. So it's just an interesting, I'm not saying that's a direct parallel, but it's just an interesting analogy. And that when we pick first doses, we tend to pick high doses, because if the medication doesn't work, we're going to throw it away and move on to a different class of drug. And we don't want to throw away a potential benefit. So it makes perfect sense to me that you don't want to underdose on your first dose study, but you're just not supposed to stop there. Somehow we got stuck in 1972. So the honest answer, Leah, is I'm doing SNACS because I want to find out what is best. Is 1 dose better than 2? Is 2 dose better than 1? Are they similar? In which case, again, if we give similar effects, we should use the lowest possible dose. It's a basic principle of pharmacology. One of my patients who I was talking to was like, yeah, doc, that makes sense. You don't take 4 tablets of Tylenol. If you got a headache, you take 2. And I was like, that's brilliant. Can I use that line? That's the best plain language conceptualization of exactly what we're trying to explore in SNACS. But the honest answer is I just don't know. I think hopefully SNACS will give us good information that we can combine with the French data and get the very best answers for preemie parents. But we just don't know yet. And we need this study, and we need other studies that question the dose, in my opinion, because we may decide we should keep doing what 1972 said, but we may not. And I agree with you. It is a little bit shocking that, like, that black and white photo of those brilliant researchers who thankfully gave us this powerful tool is pretty. It's a pretty striking visual. In 1972, most of the patients I talked to weren't born in that decade, and look at me when I say that, like. Are you got to be kidding me, right? Like, and I'm like, yep, sorry, I'm sorry, but that's where we stand. We're going to do better. I can't answer why it's taken 50 some odd years, but we're going to do better. And we're going to go on and study dosing, right? If we find one is giving similar outcomes, and we don't know that yet, but if we find that, then we need to go on and study that dose further, because we need to find the very best dose possible for our tiniest patients.
And that's partly why I love what you do. And I mentioned in the intro that I've heard you present a couple times, but I think in the medical world, it's so often trying to catch up to something that's already happened to us and try to medicate something that could be prevented. And so your work really is focused on that time that it feels almost like, I'm trying to think of that Star Trek term, like the great beyond, that the unexplored territory of, that's what a lot of families have the question marks about, because there's lots of research and more to be done once we're in NICU and kind of looking at how can we fix things that have already gone wrong. But your work is very much looking at the preventative and how can we, give these babies the best start when they're in their incubators and fighting alongside us. And so I really appreciate that about your work.
Thanks, Leah.
Sandy wanted to ask one more technical question. Why betamethasone is 12 mgs and dexamethasone is 6?
Yeah, thanks, Sandy. And I remember you're from Taiwan, and Taiwan tends to use dexamethasone, to my knowledge, or something called a different kind of betamethasone that's actually betamethasone phosphate. The betamethasone that we're studying in SNACS is a combination of something called betamethasone phosphate and betamethasone acetate. It's got a fast-acting component, phosphate fast, and a slow-acting component, betamethasone acetate. So that's what we're studying in SNACS, because that's principally what's used in Canada, the US, France, certain parts of Europe, but not all. Betamethasone and dexamethasone are actually very close cousins. They differ only by the position of a methyl group if you're a pharmacologist, but if you're not, I would say they're very close cousins. The tradition has been that in certain parts of the world, dexamethasone is used, and in certain parts of the world, betamethasone is used. Dexamethasone is a little bit less expensive than betamethasone, and so sometimes that's the reason, but sometimes there's just other reasons why tradition. Dexamethasone can be given in 2 different ways. It can be given as 6 milligrams in 4 doses, so a total of 24. Or it can be given in 12 milligrams in 2 doses, again, a total of 24. It's 24 milligrams either of betamethasone or dexamethasone. It's just a different dosing frequency. When dexamethasone is given in 6 milligram doses, it's typically 12 hours apart for 4 doses. when dexamethasone is given in 12 milligrams, it's given every 24 hours, like betamethasone. So, so why is one given over another? Partly tradition, partly a little bit cost. And I think it's just geography as well, that, you know, North America, certain parts of Europe tend to follow betamethasone more than dexamethasone, and tradition.
I'm going to let you go here in a minute, Sarah, but just want to end with asking the future of SNACS. So when will we, I don't know, when research never really wraps up, but when will we have some answers from SNACS, and what's your best hopes by the end of this?
That's a really good question that I completely honestly can't answer. I would just really invite preemie parents who are potentially facing an early birth to consider joining the study if you're in a center that's involved. We're just literally last night had a steering committee meeting to discuss potential partner countries to join with us, so we can answer the question more quickly for preemie parents, but also increase the generalizability that it's not just a Canadian study, but that other countries, then the results are directly applicable to them as well. So stay tuned, because hopefully your country will soon be involved. And the honest truth is I just can't answer that, because we're just at the very start of SNACS, and we're hoping to have partner countries. So I promise I'll come back and tell you the results of SNACS, but I just can't pick a potential date for that, because I think we're in a kind of accelerated phase now that we're looking at potential partner countries, and we're just really hoping some countries will think this is an important question, and that it shouldn't just keep on doing 1972's approach.
Mm-hmm. Well, thank you so much for joining us here for today, and for all of your knowledge sharing, and for putting up with all of our questions that, you know, they're difficult, but I always love how you just, you're honest and dive in and tell us what you know, and I really appreciate that. So thank you for being with us today.
Thank you for the opportunity, and it's so lovely to see you again, Leah.
And thank you, everyone, for joining us for this episode of Preemie Chats. If you missed part of it, or you want to rewatch it or share it with someone you know, then again, I'd encourage you to go to CanadianPreemies.org. You will find past episodes living there, as well as our YouTube channel, so you can always rewatch. And while you're there, also take a look at the many resources and support options that we offer to help families on their journey. As a charitable organization, CPBF relies on the generous support of people like you, and your donations allow us to continue empowering families of premature babies every step of the way. Together, we can create a brighter future for all preemies and their families. And speaking of a brighter future, I'm still putting this on your radar, happening November 6th. In Toronto. It is the Little Lights Big Hearts Gala, our first ever fundraising event. And if you're wondering how you can be involved, we are looking for sponsors for this event. We are about 75% to our goal or so, but we need more. And so if you know somebody who's a business owner, corporations have been stepping up and helping, recognizing that this is a wonderful cause and one that affects so many Canadians. And so if you know somebody in your life who might be interested, please send them over to our website, and we will make sure they have the information that they need to get involved with this very important fundraising event. I want to thank you for being a part of this community, for sharing your stories today and your questions. And I'd invite you to join us next Friday here at 1 p.m. Eastern for another live episode of Preemie Chat.